Yep.
On your spinal cord examination, you're going to want to make sure you also have available the dermatome man, not just the arm and the leg that goes with neurovascular, but you want to be able to appropriately test for sensory component of the exam. Each of the black dots will need to be assessed as you move through. So one part of the spinal cord exam is your sensory. The other part will be your musculoskeletal or the muscle tone. So with this part, the sensory will be in EPIC, 0 for absent, 1 for less than, 2 is normal, and 3 is hypersensitive when you're doing your exam. You must touch bilateral on each of these black dots. You must ask them if it feels the same on both sides. Does it feel different? Try to get them to describe first. If they cannot give you any descriptors, then you can give descriptors, and you'll see the different descriptors within EPIC. So I'm going to put this down for a moment. With your spinal cord exam, the other part of it is you need to know the area of where you're going to start. If it's a fracture, a disc, surgical procedure, an injection, wherever that begins, you have to go 2 levels above. So an example is a T8 fracture. You would have to start at T6 and work your way down. Within EPIC, it will show you those parts of the body that you're going to assess down both in the motor component and the sensory component. So we're going to break it down into the motor component first because the sensory is not that bad. So we're going to just start like if we had a high cervical, and we're going to work all the way down. You do have to touch your patient, so you'll see my back. So I'm going to go to the other side so you can see the patient. Hello, Mrs. Jones.
Hello.
I want you, if you can, put your arm up for me like this. I want you to push against me. I want you to pull against me. So what we're doing there is we're checking elbow extension when she pushes, elbow flexion when she pulls back. You do need to push. Keep in mind, an 18-year-old versus an 80-year-old, you don't want to knock the 80-year-old out of the bed, but you still want them to be able to push against you. Should you happen to do this on someone who's in a sling, you can still do the range as far as up and down a little bit, but you don't have as much motion, but you can still tell some strength. The strength goes on a 5, 4, 3, 2, 1 scale. You'll see that within EPIC as well. The next thing I'd like you to do for me is I want you with one hand, put it up for me, make a fist, and between my hands, you're going to rev a motorcycle. So you're going to go back and forth. Ready? Rev. Again, you're checking against them. 5 is good strength. 4 is a little less. 3, as you move down your strength characteristics, is you can move more against them than they can get against you. 2 is they can move, but once you put any resistance there, they cannot resist you, or they can't resist the gravity with the first one that we did as well to get the arms up. A 1, you're not getting anything but bare muscle movement, and a 0 is no movement at all. Be aware that your 0 could be there because of neuromuscular blockades done in surgery. The next one, same thing, make a fist, rub against me. Okay, the next one I want you to do is have your fingers open like this. I'm going to do one hand at a time. I need you to force your fingers open against me. Go ahead. Okay, and we're going to do this one, force your fingers. This is finger abduction. And again, 5, 4, 3, 2, 1. It's a little harder, 5 to 4. It's a little subjective. But a 3, you can feel they really don't have much movement against you. 2, they really can't do much at all. Bare muscle movement and no movement at all. The next one, if you can put that down, thank you, is I want you to make the okay sign, but I'm going to put my finger between your thumb and your index finger, and I want you just to squeeze as hard as you can. Squeeze, pinch, pinch. Okay, we're going to do the same thing on the other side. This is good. This is called the thumb index pinch. But if you ask them to squeeze versus pinching, otherwise you will get people trying to pinch you. So you want them to tell them to squeeze instead with that aspect. So that's the upper extremity. Then we move down to the lower extremity, and it's going to start with hips. Now, a lot of patients you'll see try to do it with their legs straight. You're using more of the back muscles than isolating. We want to isolate the hip muscles. So if you can, keep in mind if they also have external fixators, only do the motion that you can do, but assist them if need be to bend the leg up. Now I want you to use your leg and push up against me like you're lifting it up off the bed. Push and push down against them. And you do that again on both sides. We're going to do the next side. I'm going to help you bend your knee up. Just with the top part of your leg, push. Good. 5, 4, 3, 2, 1 again. The scale stays the same. Now for the next one, it's the calf kick out. But a lot of patients, whether they're in the bed and the chair, also will generally want to pull back against you, but you'll see an epic. It's only the extension. So if you can kick your leg, so if you have to, hold onto their thigh, especially with weakness, and have them try to kick the leg up and push against you. So that is your extension, your knee extension. We're gonna bend this leg up. I'm gonna put my hand on your leg, try to kick me away. Good. You'll see some physicians, they do a little bit more detail with the calf, but with an epic, we just have the knee kick out, knee extension. Next, I'm gonna come down to the feet. We're gonna do plantar flexion and dorsal flexion. Do whatever you can to get the patient to understand that you're trying to push. Can you push down hard like on a gas pedal? Now I want you to pull your feet back towards your nose against my hands as hard as you can. Sometimes if they're confused, if you wiggle their foot back and forth and say, I want you to do that against my pressure and of my hand, sometimes you'll get them to be able to do the dorsal flexion back towards you. And then for the wiggle of the toes, we do need to check them because our toes, when we're up, they're our balancers. They're gonna help with their ability to balance. Can you please wiggle your toes? With the toe, 5, 4, 3, 2, 1, it's a little harder to detect. But basically, do your best to distinguish. 5 and 4 is subjective, but a 3, they really can't push against you. 2, they really don't have much strength. They can move them, but not with strength. If you have to compare, if they're not getting much movement without your hands there, ask them to wiggle their toes and watch. That would be more of a 2 if they had no strength against your hands. 1, bare muscle movements. 0, there's no movements at all when you do your toes. So that's the motor component. The sensory component, I'm just going to show you a couple of them because based on your patient, you need to do the dermatones. And when you get to the chest, they become a little bit easier. It's almost every 2 inches down, but you need to do the same pressure. If there is a change, if there is a difference, you can go get a long-handled Q-tip, cotton tip applicator, and you have your soft end, and then the wood part becomes your sharp end to do more of a check if you need to go further. Can you feel this? Yes or no? Does it feel the same on both sides?
Yes.
And if they said no, ask for descriptors. Sharp, dull, electrical. Some people are hypersensitive. Again, you across the epic, they'll give you some of those descriptors. So as you're touching, but be in mind, and what I've seen people do is push a little different. And if you have to, you can even tap a little bit. As you move down, the differences on the hands are specific points. Again, follow the black dots on your dermatome man. It should be available to you to do your sensation checks. The hardest part out of all of this is if you have a true spinal cord tumor or spinal cord injury, you also have to then roll them over and do rectal tone, and then you need to do the proprioception as well. That's the difference for true cord tumors and true cord injuries as you work down.